Assalamu alaikum and a very good afternoon to everyone. Welcome to today's webinar presented by Genix Pharmaceutical on a topic Brivaracetam in Pediatric Epilepsy, Navigating Challenges and Maximizing Benefits. We are thrilled to have participants joining us from across the Pakistan for the session on a topic of critical importance in pediatric neurology. Today, we have the privilege of learning from the two leading experts in the field. Our presenter, Dr. Faisal Zafar, is an assistant professor and consultant pediatric neurologist at Children's Hospital Multan, extensive experience in treating epilepsy in children and has contributed significantly to research in the area. Accompanying with Professor Tipu Sultan is our expert panelist. Professor Tipu Sultan is the head of the Department of Child Neurology at the Children's Hospital Lahore and also serves as the top position in the Pakistan Pediatric Neurology Society, whose expertise in pediatric neurology and epilepsy management has been instrumental in advancing our understanding and treatment of the condition. Our session will include a presentation by Dr. Faisal Zafar and an expert opinion by Professor Tipu Sultan and question answer sessions in the end. Without any further delay, I would like to request Dr. Faisal Zafar, please proceed further.
Assalamu alaikum. I'm here as Dr. Faisal Zafar and currently working as pediatric neurologist as an assistant professor in Children's Hospital Multan. And thank you, Genix Pharma, for arranging this webinar, for creating awareness regarding Brivaracetam and their previous help in regarding the field of pediatric neurology. And so our today's topic of discussion, this is Brivaracetam in pediatric epilepsy, the navigating challenges and maximizing benefits. I also want to thank my teacher and my mentor, Professor Tipu Sultan, for giving us this opportunity and creating all this help regarding pediatric neurology services in Pakistan. So we start with the name of Allah Bismillah Rahman Rahim. So the topic, you can see my screen, Yasir?
Yes, sir.
Okay.
Yes, sir.
Okay, thank you. So a little brief knowledge and view about the epilepsy, then we go towards the further its classification, then its treatment and role of our newer anti-epileptic, that is Brivaracetam. So the epilepsy, this is defined as a disorder of the brain which is characterized by ongoing liability to have recurrent epileptic seizures. So if patient comes to you with seizure, that not only means that this one single episode of seizures can contribute to the epilepsy. Whenever we have the more on continuous and recurrent or more than 2 episodes of seizures, that contributes to make it to the epilepsy. So this is the best considered as a symptom of brain disorder and has many causes and forms. As I mentioned, that there should be at least 2 or more unprovoked seizures 24 hours apart that is required to label the patient as epileptic. So clinically, when we can, how we can see it, say that the patient is having any seizures. So first of all, the history is very important, in which there are some prodrome. That means the symptom that can predict this, that a seizure is going to happen. And then there will be the aura. That is the earliest part of the seizure, which is usually recalled by the patient. That means those symptoms and those things which is usually recalled later on by the patient, that he had came across those symptoms before, just before the having the seizure. And then there is the ictal activity. Ictal activity is the epileptic activity itself. That is abnormal activity that can be previously grand mal, patent mal. Now it can be focal, generalized, any symptoms regarding that pertinent feature. And after the completion of those fits or ictal activity, there is usually post-ictal phenomena. That means post-ictal phenomena is just after the cessation of the seizure, that patient went into post-ictal drowsiness or sleep, or he become active and then comes back to the normal baseline state. So whenever the epileptic discharges, they arise from one part of the cortex and remain limited there without spreading to any other area, that we will consider that clinically as focal sign. That means sign in a single cerebral hemisphere. So these seizures are usually called partial seizure. But whenever these epileptic discharges arise from midline, deeper structure, and they spreads to all part of the cortex at the same time, and that means these seizures are called generalized seizures. If those epileptic discharges arise from one part and spread to the rest of the cortex, these results from symptom from one part of the body, and then there is starting to the other part as well. That means they are secondarily generalized seizures. So classification is previously, before the recent onset and recent modification, ILAE classification, we have a past classification in which though which has been from the years, that is partial and generalized seizures, having later on divided into partial into two, into simple seizure, simple partial, complex seizure. Simple partial seizures had been further classified, can be into motor, sensory, autonomic, or psychic symptoms. That if the symptoms are motor predominantly, then we can say it simple motor partial seizure, and then complex. While in generalized, we have grand mal, petit mal, and myoclonic epilepsy. Now, the recent and the most advanced are the ILAE, International League Against Epilepsy. This has been modified with the years passing by, as at initially given in the 2017 and then in 2021, and with the minor modifications. So previously, we used to call that as partial seizure. Now we can say that as classify them as a focal onset. That is awareness and impaired awareness. That means if the patient remains aware with the focal onset, that we can say that focal onset with impaired awareness and aware. Later on, it can be further into motor onset or non-motor onset. Motor onset basically by the motor activity, and if these focal seizures converted into focal, becoming lately secondarily generalized, that means that these having initially focal onset and later on it converts into bilateral tonic-clonic, that it aggravates further and spreads to the other part of the other half of the body as well. Second main group is the generalized onset, in which there is motor, tonic-clonic, other motor, and non-motor. That is, non-motor is basically absence. That means the steering of the gaze, and some minor or some transient blackouts. That patient having sudden cessation of the activity which he has already doing. And the third main type is the unknown onset. It can have motor and non-motor component. Motor component can be tonic-clonic and other motor, while the last is the unclassified. Those fits, those seizures which cannot be classified into any basic category. So, in this years, what is the etiology? Initially, we have seen the classification. Now we can see the etiology, that why these seizures occur. They can occur from multiple causes. First can be structural, genetic, infectious, metabolic, immune, and unknown. Structure is usually, as the name mentioned, any structural specific abnormality in the brain. That can be due to any congenital malformation. It can be due to any acquired structural abnormality like any SOL. It can be due to any congenital brain malformation. It can be genetic, that if the patient is having seizures and there is positive family history, that similar seizure being occurring in the other sibling as well, or in the cousins as well, that means that there can be a genetic cause, underlying genetic disorder, which is causing these problems. Thirdly, infectious causes that can be triggered by any infection that affects the brain. That is any CNS infection like meningitis, encephalitis. While metabolic causes, these are new entity and very currently being studied and thoroughly research being done. That means many metabolic disorders like any organic acidemias, like any urea cycle disorder. These usually have these problems, and they can cause the seizures, because in these problems there is also underlying genetic metabolic problem. Some conditions are having like autoimmune conditions, they also can present can cause seizures, and in the end, as previously the unknown, in which there is no identifiable etiology considered. So sign and symptoms, as I told you earlier, that can be tingling, blood vision just before the ictal activity, something like aura, like giddiness, vertigo, some jerky movement that in simple words we can say that tonic, clonic movements, generalized numbness. That means something like feeling of numbness, loss of sensations, muscle tightenings, and rapid eye movements, twitching, facial twitching, fluttering. All these movements having some are the symptom that usually is described by the patient, and some can be the signs which is usually picked up by the clinician. So now we move toward that is Brivaracetam, that is Cubriva, that usually basically having now the first time in Pakistan we these have been launched by the Genix by showing that this is how this works, and now we're going to the details of this. So this is Brivaracetam, that is FDA approved as both monotherapy or adjunctive therapy for the treatment of focal onset seizures in the patients. But what are the mode of action, in which, as we all know, that all is the sodium potassium gated channels that contributes towards the multiple action potential propagation, and in turn there is no muscle activity in which there is sodium causing the depolarization, that is sodium channel. And as you previously know that levetiracetam having these sp2 receptors, now this cause this and newer anti-epileptic drug, this is basically the potent sp2 receptor, sp2a inhibitor. This causes the inhibition of this receptor, and this binds to the protein that is 15 to 30 times stronger, and as the result, the release of neurotransmitter is inhibited. And by this, there is that how by this mode of action usually seizures controlled. So the pharmacology, the absorption is this Brivaracetam is well absorbed after oral administration, as this can be in the oral form as well as IV form. So as we came across the multiple OPD patient having these seizures, so we have to give this drug in the oral form, in the syrups or tablets form. So this is pretty well absorbed after oral administration by reaching the peak plasma concentration within 1 to 2 hours. The distribution, the drug has the moderate plasma protein binding, that is approximately 20%, and distributes throughout the body, including the central nervous system. While in metabolism, this undergoes the minimal hepatic metabolism, with the majority of drug remains there and present for the effective its actions. So the potential drug interactions, we came across this when we with drug interaction we give with the rifampicin. This decrease the Cubriva plasma concentration, likely because of the CYP-C2 C119 induction, while is increases the Cubriva dosage in patient on competent rifampicin by up to 100%. That means the double the dosage. While giving with the carbamazepine, that means in which the patient is already on some carbamazepines and taking this drug interaction cause, this may increase exposure to the carbamazepine active metabolite. So but the available data did not reveal any safety concern, but the dose reduction should be considered if tolerability issues arise. That if patient is unable to take the oral, then we can adjust the dose accordingly by decreasing the dose. Whenever we give this with the phenytoin, this Cubriva can increase plasma concentration of phenytoin. So we should monitor, we can easily monitor the level of serum phenytoin during the co-administration by doing the serum blood, serum therapeutic levels, serum blood levels. While in the co-administration with levetiracetam, there are no added therapeutic benefits. So usually we should switch. If the patient is already taking levetiracetam, so we should never give in combination with that levetiracetam. We should rather switch from levetiracetam to the brivaracetam. So the side effect, there is very minor side effects, not any major. As you know that previously we used to give the previous drugs like sodium valproate and serum carbamazepine. Sodium valproate is a kind of a notorious drug. This cause the thrombocytopenia, decreased platelets, and deranged liver function test. And carbamazepine also have similar many side effects, which we all of us used to give previously for the partial seizure. But the drug like this Cubriva, brivaracetam usually don't interfere with your platelets through your thrombocytopenia and liver function test. So that can easily be given without the monitoring of so much regular serum investigation. So the side effects like dizziness, fatigue, headache, vertigo, mild nasopharyngitis, and nausea are the can be the potential side effect. So why there is need? We came across the third generation anti-epileptic because previously there is a need for anti-epileptic drug with a rapid onset of action. But in the solution is this, that Cubriva offers a rapid onset of action. So that's why it is a solution for this, that the problem arises and we need to give a solution for this, that there is a very rapid onset of action. So the second problem is around 30 to 40% individual become resistant to this. By this, Cubriva has demonstrated that there is proven benefit, and in this there is less kind of a resistance. But the third problem, there is the need for an add-on arises when a patient is already on a higher dose requiring a drug with a similar refractory epilepsy. The solution is this Cubriva. This is a better choice for patient on higher dose by providing the minimum dose per body weight. That means in the other anti-epileptics have to give the higher anti-epileptic dosage. For this, in this we can achieve the same results with a less dose. That means the dose that is milligram per kilogram body weight. The another problem we came across, that roughly 1 in 4 children with epilepsy had significant behavioral problem. This is the potential side effect which I personally also having with the levetiracetam, that the patients using the levetiracetam having these problems regarding the behavioral issues while taking levetiracetam. We previously used to give paradoxin along with that levetiracetam, but still we came across a few behavioral problems. So this emotional, behavioral, and social problems remain stable in most of the patients taking brivaracetam. So we personally have less kind of a side effects while using this brivaracetam. So now look in the scientific data, that what's about the efficacy of the children of efficacy of brivaracetam in children with epilepsy. In this week we came across, we noticed, and we go through the literature as well. There is almost more than 50% reduction in the seizure frequency. The majority, that is almost more than 90%, they are refractory epilepsy, and the median maximum dose by which we have the therapeutic effects, that is almost 4.3 milligram per kg per day. The safety and tolerability of adjunctive brivaracetam in children with focal seizure, the treatment retention. So that means the retention rate should be higher to affect the better tolerability and better results with this brivaracetam. In this, the retention rates were higher in patients with exposed to prior 1 to 4 lifetime anti-epileptic. That means they have a pretty good tolerability and safety profile as well. Many colleagues and rather specifically young colleagues used to ask that if the patient is taking levetiracetam and we want to shift that to the brivaracetam, so how it is possible? That means you can just switch from levetiracetam to brivaracetam just overnight. That means if the patient has taken the yesterday's drugs and doses from some levetiracetam, so you can easily switch to the brivaracetam just overnight by giving the second morning dose, and there's no need to taper previous levetiracetam. And secondly, we again look for the behavioral disorder and drowsiness. So that means the efficacy of brivaracetam as an add-on treatment in 262 patients with refractory epilepsy, about around 100 patients, 100 more than 105, that who are switched on the levetiracetam to newer brivaracetam. They have less than almost 50% behavioral disorders have been decreased. And the irritability and aggressiveness, as you can see on the right side, the table showing that almost 80% of the patients, the 12 out of 15, showing improvement in their irritability and aggressiveness while taking the brivaracetam instead of the levetiracetam. Similarly, the depressive symptom, they also decrease almost to 70% when they have been switched from levetiracetam to the brivaracetam. So this brivaracetam treatment can improve levetiracetam-related neuropsychiatric adverse effects. So this Kubriva, there's early add-on treatment in focal seizure. So the sustained response, sustained seizures response when we add it earlier, early add-on therapy when we did, we have came across more than 60% effect. While if added on later on, that will have less effect, that is 34%. And the sustained the seizures freedom, obviously better results with the early add-on therapy regarding the in fact, if we came add that on later on. The median daily dose of brivaracetam at 12 months was 125. That means 100 milligram in the early add-on therapy. So executive function and self-regulation categories remain stable for majority of the school-age children, that is around 5 to adolescents like 15, 17 years of age. We came across that percentage of the patient. So there is no 9 out of the 10 patients did not worsen in category when they change from baseline activity, while there is 21% of the improved in category, while there is only 13% of the worsening. So the Brivaracetam used in patient with severe acute hospital setting. This is a pretty good drug when we came across some acute recurrence of seizure or like the kind of status epilepticus. So when we see this, the Brivaracetam has almost a kind of a better results in the 6 to 8 hours, while in the relevance to the 12-hour therapy, that almost 80% having the patient, 80% of the patient having the best results. The efficacy and tolerability of IV Brevstam for status, a systemic review has been done from a total of 34 patients. 5, there is an uncontrolled study. 77 patients were included in this review. 48% with status responded to IV Brevracetam. And there is a time for the CS cessation immediately from few minutes to the some, I think 10, 15, 20 minutes. That means a very pretty good response that is efficacious and safe in terminating seizures among the patients. So the benefits, the IV Brevstam, they can be administered within 2 minutes without any delay, or usually the Tmax, the maximum time will achieve in less than 5 minutes, and we can give it with dilution in the 15 minutes time, and there is no specific cardiac and respiratory monitoring required. So the advisable dosage, this brivaracetam doses are higher than 1.9 milligram per kg or associated with greater probabilities of response in status, and consequently a minimum dose of 2 milligram per kg seems advisable for the treatment of status epilepticus. So to why to prescribe the Cubiva, that this offers, while summarizing my presentation, that this offers improved safety, better tolerability, it's better SV2 A receptor inhibition, that is rapid onset of action. It crosses the blood-brain barrier adequately. They have less drug interaction, less behavioral issues, as we see with the levetiracetam. This does not require any dose adjustment for patients with renal dysfunction, and this is economical than other available brands, and this is available in also complete therapeutic range, that is tablets, syrup. So while summarizing the dose, recommended dosage in the less than 11 kg or less than pretty 1 year of patient, the initial dose we start with 0.75 milligram per kg to 1.5 milligram per kg twice daily, and the minimum is 0.75. We can go to the maximum to the 3 milligram per kg twice daily. This is given in the BD dosage. While in the more than 1 year, or specifically we can say that 11 kilograms to the 20 kilogram, so we can start with 0.5 milligram per kg and move toward the 1.25 milligram per kg. The max is 2.5 mg per kg in the 2 divided doses. While in the 50 kilograms or more, so we can safely start with the 25 milligram and increase it to the 50 milligram twice daily. While in adults, initial dose is 50 milligram and we can move to the 100 milligram. So thank you for the kind patience and listening. So I would also like to invite my teacher, my mentor, that is Professor Tipu Sultan. to give his valuable remarks and guidance regarding any further in this regard. Thank you.
Thank you very much, Faisal, for a very nice and detailed account of this new and highly effective drug in the management of epilepsy, but also status epilepticus. Uh, since you elaborated this drug in such a detail, probably before explaining anything further, I would prefer to have some question and explanation of those questions. If there is any question, I would be happy to answer first.
Yes, sir. There are some questions in our chat box. Sir, Dr. Salva is asking from PIMS, how you compare Brivaracetam with other anti-epileptics in partial seizures?
Yes, can you please repeat the question?
Yes. Dr. Salva is asking from PIMS, how you compare Brivaracetam with other anti-epileptics in partial seizures?
So, kind of, as I told you in this, that this is having a newer anti-epileptic drug, and while previously, as the carbamazepine is our drug of choice along with the levetiracetam. So recently, there is pretty acute problem of non-availability of carbamazepine in the market from last 1 to 2 years, and we have to do the regular monitoring of those. And by doing the recent trials, we see that there is pretty good response of my personal patients when I switched from levetiracetam to the brivaracetam, and they show the clinical better results. And this obviously needs no further regular monitoring, along with no proper regular investigation, with a pretty lesser side effects, specifically those behavioral issues which I came across with the levetiracetam. I didn't have any these kind of side effects while using the brivaracetam. So obviously, this is superior.
Thank you so much, Dr. Faisal. We have another question from Dr. Anam Zafar. Will be equally effective as monotherapy, and what is the absolute contraindication of this drug?
There is no absolute contraindication of this drug. The only thing, when we previously taking the levetiracetam, we should not give in conjunction with that levetiracetam. We can just stop the levetiracetam straight away, and we can switch to the brivaracetam. There is no absolute contraindication, like we came across thrombocytopenias, deranged liver function test as from the other conventional first line anti-epileptics drugs.
Sir, Dr. Ehsan from Services Hospital, Lahore. What are the specific considerations while prescribing Brivaracetam?
The specific concentration is just, we can just start with a lower dose, that is 0.75 milligram per kg, and we just move towards the gradual increment of the dose, and look for that if the patient remains having good tolerability and the seizures control remain well, and then there is no need to further increase the dosage as we gradually increase this, and having a better good results with this lower dose as well. And obviously, if patient comes to you with a breakthrough seizure or some concomitant illness, then you can just give the easily switch from oral to IV therapy as well. That means if patient is already over there and not unable to take oral, or he is in some critical condition, and he comes to you with a sick condition, and we have to admit that baby, so definitely we can easily switch from oral to the IV and starts IV brivaracetam straight away without missing any doses, and without affecting your serum therapeutic level. So that's how obviously we can continue the good treatment further.
Thank you, sir. Another question in the chat box. Can a patient be shifted due to generalized seizures to Brivaracetam due to having behavior issues with levetiracetam?
Uh, um, the the thing is this: you should first of all look for the diagnosis, that what is the actual diagnosis that is causing those behavioral problem. For example, if a patient who is developmentally normal and not having any IQ related issues, or intellectual disability, he's not having any kind of already persisting behavioral issues like any autistic or any developmental issues. So that means, and that particular patient was taking any drug like levetiracetam or anything else which is causing those behavioral issues. So you can definitely switch them to the Brivaracetam, because we also, and the our research used to show that there is a kind of less side effects with those behavioral disorders. But if the patient is having already some behavioral problems and some concomitant illness, some behavioral disorders like low IQ, then definitely we should consider that thing as well and look for particular rehabilitation therapy along with those behavioral therapies to have a good effect for all these.
So Dr. Kashif is asking a question from Abbasi Shahid Hospital, Karachi. How brivaracetam impacts sleep pattern of a child? Is it causes more drowsiness than levetiracetam?
It usually cause less sedation or less drowsiness with as compared to the levetiracetam. As we told you in the presentation that there is the drug serum level and the drug level is low. The dosing and safety and tolerability are much better. That means we just have to give the pretty low dose in amount. The beautiful the thing about this drug is that if you start with the levetiracetam, then you have to give in almost that like we you if you a patient comes to you with a 10 kilogram and you have to prescribe the levetiracetam, then you definitely you will guide him that he has to take almost 3 cc 3 ml levetiracetam twice a day. But if you have to switch the same patient to the brivaracetam, then you only need to give that is half a cc. That means almost I think 200 to 300 times less in amount in the quantity as well as the dosage. So that is a kind of again a good beauty that most of the kids who don't have a good tolerability to the taste and to the they are usually taking 2 to 3 anti-epileptic drugs, and they are get fed up of the dosage. So easily we can go with the less dose and less sedation in the while taking the Brivaracetam.
Next question is from Dr. Raman Kumar, Assistant Professor, Liaquat National Hospital, Karachi. In how much valuation and in how much time should we give IV in status?
As I told you that it can be given in dilution, and we can use to if the patient comes to you with the status epilepticus, just like levetiracetam we used to give in 15 to 20 minutes. So we can just dilute and give into 10 to 15 minutes with no long monitoring, low any cardiac monitoring or any some this required for this. You can give and then 15 to 20 minutes.
And sir, what about according to its literature, can we give it straight
Yes,
regardless of any dilution?
yes, we can give it. We can give it in 2 to 3 minutes as well.
We have last question from Dr. Kashif from Larkana. Can we start brivaracetam at loading dose?
Pravisham, with the loading dose for the IV or oral, I'm going to tell you both that if you start with the 0.75 milligram per kg, that means initial dose, and then you can straight away go to the higher dose. But if the patient is already having taking the high dose of levetiracetam, then you can start with the load maintenance dose as well. No issue with this. There is no side effect and no acute issue with this.
All right. Thank you so much, Dr. Faisal, and thank you for that insightful and very excellent presentation and very well answered. Now, coming up next is our expert opinion from Professor Tipu Sultan.
Meanwhile, I came across another question in the chat box that how you can you use it in generalized as first line or as monotherapy. So this can be started Brivaracetam in monotherapy as well as the in the generalized epilepsy as well. Obviously, in the adjunction therapy as the co-therapy with other drugs.
Answer another question followed by how you compare brivaracetam with lacosamide in focal seizures.
I think as the patient is having with a less age, as the patient is having just 1 to 2 months, so we can give Brivaracetam in the lower age group, and I think Brivaracetam is more better than the lacosamide for that focal seizures. So here's Professor Tipu.
Any further question left, Akil?
No, sir. All questions answered, sir.
All questions answered. I think
we need your expert guidance.
I think once again I would reiterate whatever explained in detail in the past 40-45 minutes by Faisal. Since it is one of the remarkable drug, the I would say next generation in the of in the family of anti-seizure medicine, historically called as anti-epileptic medicine, and currently by the recommendation of ILA, we used to call them as anti-seizure medicine. Because what ILA explained, all these drugs are actually anti-seizure medicine, not anti-epileptic medicine, because they treat individual seizure or electrical seizure activity in the brain. So it's the good thing is behind this that now for the past few years, whatever new generation anti-seizure medicine is available globally in a few years' time is marketed in Pakistan as well, which is good for the huge number of patients affecting with epilepsy or other neurological disorders. So hats off to the manufacturers and the persons behind this remarkable activity. The credit goes to the whole team, and of course, my my shining star student, Faisal Zafar, and team of the person behind the screen, led by Sajazmi and Akil, and all those who are uh, involved in organizing this. Last but not the least is the beauty of this drug. Whether it's Levi or this is the next generation Brevi, is the potential side effect free, potentially no interaction with the drugs, and ultra short acting. Not short acting, I would say ultra short acting. Almost we can say, but I can foresee in the coming years or coming decades, it would be the drug of first choice. It would be the drug of first choice in the management of seizure. Though I'm not the among who can say at this stage, but I'm very sure about its inclusion in the after benzodiazepines among the long-acting drug as the drug of first choice. I'm talking about the phenophosphatidylcholine and phenytoin. It would be in the second step or the first step of the long-acting anti-seizure medicine in management of status epilepticus. This, to me, this might be the future of this drug, of this salt, because of its ultra-short acting. G. Faisal and Akil, any further question?
Sir, thank you so much. Thanks a lot for your valuable comments and your time. Thank you so much, Dr. Faisal, that you have given us this opportunity to present Brivaracetam. And thanks all. I would like to thank all the participants who attended this program. Thank you so much, Yasir, for being here with us. Thanks a lot, sir. At last, I would like to thank all of you, sir.